Okay, we're going to continue with genetic disorders. So the simplest ones to understand are the single gene disorders. This is when a problem with a single gene causes a disease or a disorder. They can be grouped in a couple of different ways: autosomal recessive disorders, autosomal dominant disorders, or X-linked recessive disorders. So there's the sex-linked disorders. So if there's a chromosomal abnormality, a problem with one or more chromosomes, and it happens during the separation or crossing over, there can be this chromosomal abnormality. So this could mean that the individual has 22.5 pairs of chromosomes or 23.5 pairs of chromosomes. There can be some sort of abnormality. So that's not a single gene disorder. This is a chromosomal disorder. So we can have abnormal number of chromosomes. So monosomy is when you only have one copy of the pair. Polysomy is when you have more copies of the pair. Most monosomy is incompatible with life. They don't even develop as a fetus. So some typical chromosomal disorders would be Down syndrome, Klinefelter syndrome, Turner syndrome, right? So you see that the normal karyotype is all the pairs. You will see that all 23 have pairs. This one shows 2 X's for female, XY for male. And we'll just kind of leave it at that. We'll discuss some of the other ones. So trisomy 21 is Down syndrome. And you'll notice that the 21 chromosome, the 21st chromosome, has 3 instead of 2. So it's trisomy in chromosome pair 21. Now, this is a male person with Down syndrome. Here. So they have the extra 21st chromosome. It's a common chromosomal disorder. It's and that's mainly because it is quite compatible with life, and some people with this do very well. It's 1 in 700 live births. When you think about that, that's a huge number. Back in university, my major at McMaster was genetics. And I remember my first genetics course, Dr. Threikelt. He was one of Canada's leading geneticists at the time. He was head of the biology department, and he was this imperious British guy, and he spoke in absolutes, and he was an interesting read, horrible lecturer, but whatever. He was very steeped in his own opinion. And I remember him talking about trisomy 21, and he said, invariably these people suffer severe mental retardation. And a hand went up in the class, and it was a first-year genetics class, so there was 250 people in the room, and his hand went up in maybe someplace around the 5th row. And he said, yes. And she said, Dr. Threichelt, I beg to differ. And he kind of was, you beg to differ? Like, kind of, how dare you? And she stood up, and she had all the classic signs of Down syndrome. She was, she had Down syndrome, and she was absolutely brilliant. She got the highest mark in biology in my graduating class. I knew her for 4 years, and she was our class valedictorian. She was absolutely brilliant. So it's not necessarily, there's variation is, I guess, the point of that story. So if you think about Down syndrome, there's things like low set ears, epicanthal folds, a very flat face. This used to be called mongoloidism because these people looked like they were Asian with the epicanthal fold and the flat face. Abundant skin in the neck. Simian crease is the hand fold, so the lifeline and the whatever line, the other heart line, I guess, join to one another. Oftentimes, these people have heart defects. Usually it's minor. They often will have umbilical hernias, stenosis in the intestines, maybe some problems with blood cell production in their bone marrow, a gap between the first and second toe. Hypotonia means flaccid muscles. Oftentimes the tongue is too big for the mouth, so they tend to have a protruding tongue and drool. Not necessarily all of these things are present. Not necessarily, it's just not necessary. Now, I know someone whose son has Down syndrome, and he has most of these things that are on this list, but I found it interesting that she has very low set ears and an epicanthic fold. And those were the only things. So maybe she had trisomy 21 and it didn't manifest. I have no idea. To tell you the honest to goodness truth, I've never brought it up with her. So here's some of the clinical manifestations. Susceptible to respiratory infections is often a problem of this atonality and the large tongue. You can see this classic facial features, low set ears and epicanthic folds, which is demonstrated here, is what makes them look Asian, like the Mongoloid race, if there was such a thing as races. This simian fold here, you see how the folds in the lines. Some sex-linked chromosomal disorders, so these would be, so Klinefelter's is fairly common. There's an extra X chromosome, so it's a trisomy 23, I guess, but it's an extra X chromosome. The person is male because they have the Y chromosome, but they demonstrate a lot of female characteristics and abnormal sexual development. So you can imagine that this is somebody who has these increased female characteristics, but is genetically male. So atrophied testicles, so therefore infertility. tall height because because puberty, if it happens at all, is delayed, and so the closing of the growth plates is delayed. So that's the long arms and the long legs. Female hair distribution will have breasts and high-pitched voices, often have impaired intelligence. Not that that's a female characteristic. That's not how this was intended. These are the lack of testosterone. And that's the biggest thing, is that these people, because of the atrophied testicles, don't produce testosterone. There would also be very low libido, etc. Turner syndrome is a monosomy X. So there is no second X or Y. So this person, because the only thing they have is X, is female. It is usually because of a lack of the other chromosome coming from the father. So it happens if the father is of advanced age, because with age comes more and more mistakes in meiosis. They have a high mortality rate just postnatally, so they often die as babies. Short height, a webbed neck, sterility, amenorrhea, congenital other defects, especially heart, wide chest, so low hairlines, nevi. So here's a picture of somebody with it, and you see there's the missing chromosome. Now, there are other sex chromosomes, like there's XYY, but it's not normally considered a disorder, although it seems that there's a higher percentage of people in the prison population that have it than in the general population. There are triple X ones. Again, they don't usually manifest as any disorders. So these are the big ones. So to go back to the single gene disorders, we can use Punnett squares to look at probabilities. It's often some sort of a gene that will code for a protein, and proteins as enzymes, regulatory proteins, structural proteins. Most of them get passed down, but some of them can be novel, new mutations, on exposure to radiation, etc., in the parent. There's the autosomal dominant disorders. So that means that the affected gene is a dominant gene. And it's got to be on at least one of the autosomes. So the person has this dominant affected gene. So that means that the parent had to have had this dominant gene, so at least one parent will be affected. If one parent is affected, if you put that in the Punnett square, then half of the children will have it. 1 in 2 chance. If 2 people have it, and they only have one copy of the defective gene, then there's a 3 in 4 chance of it producing an affected offspring. If but one of those offspring will be actually homozygous with the defective gene, 2 of them will be heterozygous. All of the offspring of that homozygous will have the disease. It doesn't matter what the other parent is, because all of the offspring can only get the defective gene from the parent. So if it's the homozygous dominant bad one, and that would be one of these 3. So the only way that can happen is if 2 heterozygous people have children. So this is affected parent, normal, so half the children will be affected. Both of these are heterozygous. Half the children will be normal. They won't have it at all, and they can't pass it along. The affected parent and an affected parent, if they're both heterozygous, 1 child will be homozygous. 2 will be heterozygous, 1 will be normal. But any offspring of this person will have HH, and it will be 100% of their offspring. So some autosomal disorders, there's a disease called Huntington's disease, familial hypercholesterolemia, Marfan's, autosomal dominant polycystic kidney disease, this is a picture of, hypotrichinosis. So it works like this. So there's a dominant, this person is affected, half of the children are affected, and it passes down. Marfan syndrome is a syndrome of connective tissue, how the genetic coding to make connective tissues becomes screwed up. They have arachnodactyly, so which means spider-like fingers. They have long, thin arms and legs. Skeletal joint deformities, cardiovascular lesions, especially of blood vessels. So the blood vessels aren't as strong, so there's more chance of dilation. They can have problems with heart valves, dysfunctional heart valves, because again, it's the connective tissue is malformed. This is what a person with Marfan's looks like. You notice the long arms and legs and feet and hands. There's severe kyphosis. There's deformation of the sternum. There's another, so spinal cord deformities. I've only met one person that we suspected had Marfan's. He was a classmate of mine, super intelligent guy, but he was hugely tall and thin, and he had some deformities, and he had these huge hands with spider-like fingers. And now these people, so this is the arachnodactyly, which means the spider fingers. They have this ability. They have mitral valve problems. They tend to die fairly early because of these arterial and vascular problems. It's interesting, the guy in my class that we suspected had it, I knew him well, and he died. He he was 41, and he died of heart irregularities. So who knows? He was never formally diagnosed with it. Huntington's disease probably became famous. You guys are probably all too young, but there was a very famous folk singer named Woody Guthrie. He wrote "This Land Is Your Land" and a bunch of protest songs, and he was very active in the 50s and into the early 60s, and he had Huntington's disease. And it's a neurological disease. It's called Huntington's chorea because it causes involuntary movements of the arms and legs, and it looks like they're dancing. They have a lot of trouble speaking, and then they have a really early onset dementia. And it happens around 40 years of age. So they live a very normal life until about the 4th decade. The problem with this disease is that you don't know if you have it, and because it's autosomal dominant, 50% of your children will have it. And usually you're done having children by the time the symptoms first show up. And then you have to wait 40 years to find out if your children have it. So Woody Guthrie's son was a very famous singer called Arlo Guthrie. Arlo Guthrie had a bunch of hits in the 70s. A huge album called Alice's Restaurant. And he was a real influencer on music. And he spent his life wondering if he was going to have this disease. And sure enough, he ended up having it and went the way of his father. There's this protein, this irregular protein, just accumulates in the brain and causes a diminution of the brain. It's probably a lot like Alzheimer's, where you end up with these aggregates of inappropriate protein in neural tissue. The autosomal recessive disorders, when it's autosomal, that means it's not sex-linked. It comes from having two carrier parents and then a heterozygous recessive offspring. So, like I said already, my son has autosomal recessive polycystic kidney disease. So my wife is a carrier, and his biological father was a carrier. And he, unluckily, was the 25% that ended up having the autosomal recessive disorder. So any child that he has will be a carrier, but they won't have the disease. If any one of his children have offspring with another carrier, then 25% of his grandchildren will have the disease, etc. So it usually skips a generation. Now, this is one of the real problems with people having offsprings with biological relatives, because these things run in families. These recessives as carriers will run in families, and therefore there's more of a chance that they will get expressed. I tease my wife that her first husband was probably her cousin, and she doesn't find the humor in it. This is why so many of these autosomal recessive disorders run in the royal families of Europe, like things like hemophilia, etc., because of consanguinity. They're all related to one another. So to be affected, you have to be heterozygous recessive, or homozygous recessive. The heterozygous are carriers, but they don't have the disease. So, and like I say, it skips generations. A lot of people are carriers and they have no idea they're carriers. Like, so when we actually do some research into the family history for Jeff, we don't know, because it probably skipped a generation, maybe 2 generations. And back in those days, this disease normally would kill infants. So it was, well, the baby died, and that was about it. We don't know what they died of, and so therefore we wouldn't know. And what's interesting with Jeff, well, when I graduated in 1986, Jeff was born in 1986. My last textbooks mentioned this disease. There's a textbook I used called Current Medical Diagnosis, 1984. It mentions the disease and says you will never see this in clinical practice because these children do not live beyond infancy. Jeff is the first group where they actually had therapeutics that would keep them alive, and he's had to have a kidney transplant because of it. So he's kind of the leading edge of people that have grown into adulthood with this disease. So famous ones are things like cystic fibrosis, phenylketonuria, sickle cell, Tay-Sachs, albinism, right? Color blindness. Well, I'm actually going to take color blindness off this list. Color blindness is normally considered a sex-linked one. We'll see this in a couple of minutes. So we'll come back to this slide later, but if you see the 29, you are not colorblind. If you can't see that, then there's a good possibility. So autosomal recessive kind of works like this. So it skips a generation before it can manifest. Now, it doesn't skip a generation if somebody that's affected with the disease has children with a carrier or another affected person. Cystic fibrosis it's a problem of transporting chloride atoms. So these people, they have problems with osmosis and sodium. Their tissue secretions are abnormally thick, and so it blocks bronchioles and pancreatic ducts primarily. Their sweat is excessively salty. It's a hereditary disorder. The primary problem is being able to clear the mucus out of the bronchioles. It can cause inflammation and therefore scarring in the lungs. There's advancements in therapeutics that help these people. Lung transplant is a viable option. This is what an X-ray looks like. A lot of people with cystic fibrosis, it's not just the breathing problems, it's the pancreatic ducts, any exocrine ducts really can be blocked. These people usually have to take digestive enzymes along with their food. One of the symptoms is clubbing of the distal phalanges. with this angle on the distorted angle on the nail bed. It's not pathognomonic of cystic fibrosis, it's pathognomonic of low oxygen levels. So a lot of people with heart disease, go back to it, a lot of people with heart disease, people with COPD, people with lung diseases, can all have this clubbing. So the X-linked recessive disorders usually occur in males, and they're carried by females. So the mother has, on the X chromosome, has the normal disorder gene and a recessive gene. So the mother is normal. The father has the normal and a Y. So the female children are this half, normal, 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 abnormal. The male children are normal if they get the X chromosome, the normal X chromosome from mom, or the disorder if they get the disordered chromosome from mom. Father doesn't contribute. If there's an affected father, then 50% of the girls will be carriers and 50% will be affected. And 50% of the boys will be normal and 50% will be affected. Normally speaking, this is what we see the most often. People that are affected, that have this X-linked recessive disorder, generally know about it, and most of them choose not to father children. There's a lot of counseling goes on, and very seldom do we see this arrangement. So we don't normally see Y chromosome disorders. The X-linked disorders are recessive, so men disproportionately express the disorder. So the father transmits, if the father is affected, he will transmit the genes to all the daughters, but not the sons. Unaffected don't have the defective gene, so they don't pass it along at all. So females can be affected if mother is affected or is a carrier and the father is affected. That's the only way that it works if you follow the Punnett square. These don't happen very often because of genetic counseling. The two big ones are Duchenne's muscular dystrophy and SCID, which is combined immunodeficiency disorder. That's the bubble boy. It's a severe defect in the production of lymphocytes, T and B lymphocytes. Oftentimes, these children succumb to infection very early, and it's only been recently that we can save these children because we can identify it. Muscular dystrophy is a whole thing. I will post a video on MD. It's one of the interesting things about MD is that invariably in Duchenne's muscular dystrophy, the mother is the carrier and it's the son that has the disease, and it takes years to manifest. It is an inappropriate protein that links the myofibrils in a muscle to the cell membrane, so the muscles break down, and it's a progressive weakness. At first, it's the muscles of the legs because they're used the most, and then when the child ends up in a wheelchair, it becomes the muscles of the arms, and then it becomes the respiratory muscles, and often death follows. And I've known quite a few people with this disease, and one of the salient things that I see is the amount of guilt mothers have over this. But I will post a short video on that. So this is how the pedigree works. These are carrier women, affected men. So it's the lack of dystrophin, or it's poor dystrophin, usually fatal by age 20, loss of muscle tone, weakness, often cardiac problems. Hemophilia is an X-linked disorder about clotting factors. Runs in the royal families of Europe as an X-linked recessive disorder. Okay, other types of disorders are multifactorial or polygenic disorders. So these are things that run in the family. These are things that genes load the gun and environment pulls the trigger. Hypertension, various types of cancer, diabetes, congenital heart defects are all fall into this category. So club foot, cleft palate, heart defects, anencephaly, hydrocephaly, breast cancer. You know, they say that if you have the genetic predeterminants, like so if you have the receptors to estrogen in your breasts, that it's far more likely that you'll get it. I made mention of my family history with colon cancer, but there's a number of factors. You all know what cleft lip looks like. Luckily, it can be repaired surgically. Cleft palate is like cleft lip, except it extends into the palate. So then there's things that are just environmentally induced. So these are teratogens, congenital malformations, and usually it comes from exposure early in gestation. The earlier it happens, the more kind of severe. So errors in development, interfering with the proliferation of cells or the differentiation of cells in the embryo or the fetus. So when you look at the things, so in weeks 3 to 6, the central nervous system is developing. A teratogen will probably hurt the central nervous system or the heart. In the second trimester, or in the second part of the first trimester, development of arms and legs. And so thalidomide was often given to women when they were pregnant. It was an anti-nausea drug, and they usually started to take it around 6 weeks of gestation, when the morning sickness was the worst, and these children were born with badly deformed or missing arms and legs. etc. So these, anything in the first 2 weeks will probably mean just spontaneous abortion, like the death of the fetus. Anything after 8 weeks, it's more minor morphological defects. There's all kinds of teratogenic agents. Alcohol and various drugs are considered it. Infectious agents, especially viruses, but there's the mnemonic to remember it is TORCH, toxoplasmosis, which is actually a eukaryotic parasite that's endemic in cats, and so it comes from litter boxes. Others, which is pretty wide open, rubella, which is red measles, cytomegalovirus, herpes virus. So, or radiation will do that. So that would be X-rays, and that's the reason you don't X-ray pregnant people unless it's necessary. So these are some of the things that can happen with the TORCH. We do screen, so we do ultrasounds, serum screens, amniocentesis. We look at the pedigrees, genetic backgrounds, family histories, etc. So this is what an amniocentesis looks like. There's ultrasounds. To kind of be pre-warned for these things.